Hello from Geneva, and we have an hour for this conversation, and we're delighted that we were able to put together a really interesting group of people to discuss COVID-19 and the humanitarian implications of it around the world. We are probably maxed out on Zoom, so if anybody's asking, they should chase us down on Facebook, where the live stream is equally available. Jeremy should be here. I can't quite see him, but maybe he's like in his pajamas. Ah, there we go. So welcome to the largest group of aid workers in their pajamas ever assembled. I think this is a historic moment, and perhaps one that we can stick with audio. So this is a kind of catchphrase that WHO came up with recently, I think in 2018, was disease X. Disease X was probably going to be a zoonotic disease coming from animals. It was going to spread through the world. It was going to test pandemic preparedness, health systems, and every other aspect of society. This they called, interestingly, a knowable unknown. It was something that was quite likely, but its exact dimensions were not going to be easily predicted. So now we have the rich world. I'm going to speak for a few minutes and then get out of the way of our panel. The rich world is grappling with this unfamiliar experience of being in a crisis, of having a humanitarian crisis, not something they're familiar with. It starts with like not having something you're used to, or a small thing like your conference is cancelled or your project goes off the rails. Your holiday is nuked, but then the pace catches up. Your freedoms are actually limited. Your access to supplies, your income and your salary could be up in the air. What happens next year is unclear. So we worry about the old and the weak and our relatives and friends and loved ones. The whole experience of what's normal is changing, and you worry about the basics. You're having conversations that you wouldn't normally have. And a conversation with my mum last night, she said, in a sort of blitz spirit way, she said, well, she's very old and she's living on borrowed time anyway. This is not a normal conversation to have, but it does make me think the rest of the world, the less fortunate parts of the world could be forgiven right now for experiencing a little schadenfreude. Where were you lot? Where were you lot the last decades? You're crying about your toilet paper and your Premier League tickets and your Glastonbury being cancelled. What did you think it was like out here for the rest of us? Who frickin' who? So I think we do have an opportunity here to try and see the world as others see it, as the comfortable can see the world of the less comfortable in a new way. And perhaps that would be a plus from all of this. If you grew up in Bosnia, you grew up as a teenager in Syria, you didn't expect to see this kind of collapse of everything that you trusted and found normal. We are all fragile now, but we're not equally fragile. And it does seem that a lot of the world is a sitting duck bracing for impact. Something's gonna happen, and it's started already, and it's just getting going. And even beyond the kind of health needs, the social and economic disruption, instability, unemployment, political possibly unrest, and even violence could be reasonably possible. So in Italy, I don't know if you saw, they're transporting the dead bodies in an army convoy. So if that's the level of emergency in a rich part of Western Europe, it doesn't take a huge amount of imagination to look at some pretty grim prospects elsewhere. So the reason for having this talk today is time to take this stuff seriously. It's time to ask the difficult questions. It's time to consider what's possible and maybe what's not possible in limiting the impact of this disease around the world. The international humanitarian community have done tough places, tough diseases, cholera in Yemen, Ebola in DRC, measles everywhere, HIV, AIDS. there is, if anything, a solid background of capacity that we hope could be put to good use. I was on a call yesterday and a donor official said, we are preoccupied with ourselves. And I think we're not seeing very much talk about international aid. We're seeing a lot of concern among the rich countries about propping up their own economies and their own health systems. It's time to take the bigger picture. We've gathered together these 4 guests coming from, I think, complementary sides of the response and the international community. And we will very much look forward to you joining in with your questions. We probably won't get to very many, but we'll try and add them at the end. So the structure we've gone with is we're going to talk about the immediate, right now issues. We're going to talk about the next week, and then we're going to talk maybe next week, next month. Then we're going to talk about next year and try and see if that is a sensible way to organize it. But if the conversation goes off on another direction, that's fine too. So I'm going to ask all of them to introduce themselves as we go along. I'm not going to do bios. You can see their professional affiliations on the page. So I'm going to start with you, Virginie. What are you working on right now today? What's on your mind?
Hi, Ben. So I'm working for a Lebanese NGO, Amel Association International, and one of our key sectors of expertise and action is health, and in particular, primary healthcare. So even though the number of cases of COVID-19 is still quite limited in Lebanon, the latest figure are less than 150 cases. We are actively involved in the surveillance, in the awareness raising, and in the treatment of whatever is needed for primary health care, because indeed, access to health also means that you have to be cared for other things. And we're also working in close partnership with Lebanese public hospitals and relevant international agencies to ensure that referral takes place from the informal settlements and from the different shelters to this secondary healthcare. So what is in my mind right now? I've been struggling since yesterday evening, trying to think about something positive, because it's quite difficult to be positive right now, in particular in Lebanon, where we are accumulating lots of different crises, humanitarian crises, since the beginning of the Syria crisis, 2011, 2012, but as well a very acute socio-economic crisis since mid-2019 with collapse of the banking system almost, and 200,000 job loss since 3-4 months. So it's quite difficult to be positive. But just before this webinar kicked off, I received messages from colleagues over WhatsApp, because indeed we're working a lot over WhatsApp, and they were sharing with me those messages, awareness messages prepared by the social and outreach workers at the field level. And I thought, wow, this is positive. And this is what's in my mind, is that the locally led response, the community-based initiatives are working despite the fear, because all those workers are quite afraid, and we can understand they are directly exposed. And those frontliners are indeed exposed as well to very high levels of stress since the beginning of the Syria crisis, but still they've been able to come up with those messages and with those very, for me, innovative ways of spreading those messages. Yes, with the mobile medical units, indeed. Yes, with the primary healthcare centers, but as well with WhatsApp, with phone calls, being able to manage cases. And for me, this is what's in my mind right now, is that we have a good locally led response, but, and I'm sure we'll talk about it later on, it needs to be better coordinated with other actors in country and at the international level. And yes, this is it for now.
Thanks. What about you, Jeremy? Good morning. So is it very early where you are? Are you fully dressed?
I am. So I think this is going to be obviously an enormous challenge for the humanitarian world, and I don't think we fully can see yet the dimensions that this will, the dimensions of all the impacts that this will have. But I think we know enough now to know it will be extensive. I think partly, Ben, as you said, it is making us preoccupied with ourselves, in whichever ourselves you might be talking about there. If that's a UN agency, they're going to be focused on their own teams and their own staff. If it's an NGO, similarly, my wife works for a large NGO, and they are trying to keep their work going, but at the same time, everyone working remotely, everyone kind of concerned about whether they might get the disease. In donor capitals, the preoccupation is much more with the threat to their own homelands than I think it is to the overseas settings right now. So the humanitarian community has an important role to play, I think, in keeping a global focus on the most compromised and most vulnerable settings here. And I think it's notable that when Dr. Tedros declared the public health emergency of international concern now back in February, his biggest concern at that point was low-income, underdeveloped countries. That he saw at that point clearly that they would be the most at risk. And when you look at what's happening now, even in high-resource countries with sophisticated health systems, I think it does raise real concerns about what might happen when this begins hitting traditional humanitarian, if you will, settings. I am particularly concerned about camp and informal settlement context, if you will. It's almost certainly in IDP camps in Syria already. There have been reports of it in IDP camps in Iraq. I just heard this morning there are reports of it in Cox's Bazar. This will get into, this will be in all those settings. It will be in the POC site, the protection of civilian sites in South Sudan. And you would have a hard time designing a more dangerous setting for the spread of this disease than an informal IDP settlement. You have a crowded population, very poor sanitation, very poor, kind of low level of basic kind of health within the community, very poor disease surveillance, very poor health services. So, this could be extraordinarily dangerous in those kinds of settings, and I don't think that's getting enough global attention yet. So there's a lot of, I think there's a lot of concern in NGOs. NGOs and humanitarian organizations face a difficult balancing act of, on the one hand, keeping their own operations intact, because there is a definite continuity of operations challenge that this is posing for everyone. So keeping their own operations intact while also then pivoting to begin addressing this brand new challenge. And it reminds me a little bit of what we were facing on Ebola in 2014, back when I was still at USAID, and we all collectively had our hands full with South Sudan and Syria, and there had just been the super typhoon in the Philippines, not much before that. So huge crises already on our plates, and then this came along. And so I think that there will be challenges. What I take a bit of, I won't say optimism, but maybe cautious hope in, is that we have done this before. We have faced the situation where a brand new crisis comes out of nowhere on top of everything else that we're doing. And I think we have a few assets that we've developed in the last 5 or 10 years of humanitarian practice that are going to be helpful here. One, obviously, is the lessons from the Ebola experience. So we now have a lot more NGOs that have some, are familiar with infectious disease and public health programming, that know, having some experience with doing disease surveillance, with doing infection prevention and control support to health facilities and things like that. So I think that's an asset that probably didn't exist, at least not at the scale it now does, prior to Ebola. We also have a global infrastructure. There's a humanitarian presence in all of these most difficult places in the world, and so that gives a kind of a degree of reach that I think is really important. And we're a lot better at working remotely than we were 10 years ago, and working with local partners than we were 10 years ago. We're not still where we need to be, and I think that this is going to be an interesting moment in the whole localization kind of process within the humanitarian sector, because it's going to really force a more effective and more supportive and frankly more respectful and power balanced way of working between international partners and local partners than I think we've seen before. A couple priorities that I would see for humanitarian organizations in the weeks ahead. We need to be working on developing kind of low tech approaches to things like personal protective equipment, infection prevention and control, I would, we should make sure as a baseline thing that there is the ability to do hand washing at every health facility and every public facility and every camp, right? For those of you who worked on Ebola, you'll remember you couldn't go anywhere in Liberia without running into a chlorine stand to wash your hands. We need to do that here. Hand washing didn't do that much good for you on Ebola. It actually does do a lot of good for you with COVID-19. So that's, those sort of simple but effective solutions need to be rolled out really rapidly. We know that the mortality rate with this disease is highly correlated to age and particularly to people who need oxygenation. That's very difficult in a low income health setting because they don't have much access to ventilators. I don't know enough about the particular kind of the medical particulars of that to know if there's a good low-tech alternative that could be found for that, but I think that needs to be looked into. And then, key lesson from China, South Korea, and frankly, the US is that testing is really important. If you test widely, you can see what you're up against. If you don't test widely, you're blind. And so figuring out a scalable low-tech solution to testing in some of these settings will be really important. Thanks.
Thanks. That's a broad sweep. Thank you very much. I'll come to you at the last, Carl, especially on the medical stuff. But Suze, what's on your immediate mind and to-do list?
There's a lot on my to-do list, Ben. But on my mind is how we absorb this shock but maintain our existing programs. And particularly as I see one of the key concerns that we're seeing in countries like Somalia is a pervasive sense of anticipation, where humanitarian workers that we will rely on to respond to this crisis, but also to all the ongoing crises that are the reason we're in the country in the first place. There's fear, there's a lot of misinformation. Staff will be, I think, more and more reluctant to become too involved. They will be fearful for their own health, safety, families. And as the world has become more inward looking, as have organizations, so will national humanitarian staff. So not only how do we respond to COVID-19, but how do we ensure that the things we've been working on for years around food access, around kids going to school, which is already seeing major disruption, how do we make sure those things are able to continue as much as possible and mitigate the fears that we're seeing in our staff? I think any of us here on this call that would be honest about our success as a humanitarian community at mainstreaming protection would also acknowledge that mainstreaming healthcare will not be done overnight. We're seeing a lot of misinformation spread. We will be relying on non-health experts across areas that Jeremy just described to be doing health promotion and spreading messages when they themselves are not experts in this. So I think that's a major concern for me. It's a major concern as an advocate in terms of balancing our responsibility to remind wealthy countries and high resource countries that this crisis will hit so much harder in some parts of the world than they're seeing, without seeming sensationalist or hysterical, because that messaging actually does a lot of damage for the aid workers we're relying on in country. When we use dramatic language, when we shout too loud about this will be a disaster, our staff, the people we are all going to be depending on, simply become more frightened. So all of this is about, the buzzword we're all looking at now is business continuity. What does that really, really mean, given the exposure of our own staff and perhaps their lack of expertise?
Thanks. Carl, on the medical side, how much fear, what are the projections? What is the science telling us?
Right, okay. I'm probably not as optimistic as Jeremy, that's for sure. The new figure we received this morning from WHO is that you have around 200 cases confirmed in Africa. It's way underreported. So that's my fear. I think that the fear that actually the capacity of health system in the countries we're talking about, where a lot of crises are happening, are far too low. Today, there are more than 100 countries affected by the virus. probably 30 of them have refugees, over 20,000 people. And if you talk about the health system capacity to contain the virus or the pandemic, I can see that in four different areas. One is about preventing, and I think Suze were talking about that now, preventing. And I think you say business continuity. I'm not sure that's a solution. So we probably contradict you on that, saying you need to identify what is essential and postpone anything else to avoid mass gathering. It has to start now. I think that's your responsibility to do it. The second sphere, I think, is about detecting. And Jeremy talked about the testing. It is an issue to me in a sense that, yes, testing has to happen. It is the priority. The problem is countries in low-income countries are probably arriving on the third wave after China, after Europe, and now the third wave. Access to tests is going to be problematic. Access to protection gear for healthcare workers is going to be an issue. I mean, you talk about low tech and so on. I think we need to talk to the private sector to make sure that they raise their production to increase global access to this equipment. The third aspect is about responding to the pandemic, and it's about case management, it's about triage. A lot of people have used the term of war. I mean, the French president this week used "we are the war" in France and in the world. I'm not really sure about this kind of terminology. As you said, Suze, we're not here to raise the fear of populations. What I agree with is that for sure we need to use what we are expert in the humanitarian sector, which is mass casualty. So we look at China, we look at South Korea and experience in Europe as well. Mass casualty is going to be essential in the sense that we need to make sure we can create field hospitals to separate suspected cases with confirmed cases. And this, we can do it in the humanitarian sector. But it has to start now. The preparation has to start now. And the fourth aspect to me is about exactly what Virginie and Suze talked about, is about routine services. They should not be interrupted. We're still going to have a lot of deliveries. We still have a lot of chronic care patients who need to get access to their medication, diabetes, HIV/AIDS, and so on. What we need to do now is to make sure they've got 30 days of medication and can go home and isolate themselves, making sure they protect themselves. And I think in the humanitarian sector, where we're very good at is about prioritizing. We know there's a lot of aspects we don't know about this virus. But what we know is actually the target population, exactly what Jeremy described. And what we need to do is to target these people, making them well protected, all these people over 70, and also target the hotspots. And that's something as well we know how to do it in the humanitarian sector. I will stop there at the moment.
Thanks. Suze, you were talking about misinformation, and before the call we talked about vulnerable groups in Somalia. How do those two things make each other worse, if you see what I mean?
Well, I think we can probably look at what's been happening in high resource countries, where people are believing all sorts of things and behaving in some very odd ways, and stockpiling and panicking, and then transfer that to a context where people have a lot less exposure often to particular sciences. They've had less access traditionally through their lives to Western medicine, I suppose, and can rely on other means to less resources to deal with illness. What we're now seeing, in Somalia in particular, is something the government and WHO have also referred to as an infodemic, where misinformation is spreading at a pace that we cannot keep up with. And we're talking about people who are so concerned. People are very well aware that their government doesn't have the resources to deal with this. People are very, very concerned about what this will mean if it does hit. It's like people are braced for a tidal wave. And so I think what I'm observing is people comforting each other with all sorts of remedies and myths about what will work for COVID-19. So and if this is among a group of, I mean, the people that I'm speaking to about this are highly educated, very well exposed people, but the impact on their ability to carry a safe message to communities and on communities to absorb that message and the behavior change it will require is extremely worrying. I think the most vulnerable people will be hit very, very hard because they're the ones with even less access. They are reliant largely on humanitarians to access information. So I think the information is one of our biggest concerns.
Thanks. Virginie, you are also talking about how the fear is directed at certain groups and it's becoming tinged with stigma. And can you talk about that a bit in Lebanon?
Yeah, so it is true that in general, there are tensions between refugee and host communities in Lebanon prior to the COVID-19 situation, but there are also tensions among communities in Lebanon. And this third layer of crisis is definitely potentially increasing the stigma. We've been seeing some examples of municipalities preventing movements of Syrian refugees, but as well tensions between Lebanese communities. So this is happening right now. However, I'm always very, very careful when it comes to tensions and stigma, not to over exaggerate what is going on. It's Susie, you were talking about the catastrophic language, and I think that we have to be very, very careful. We have to advocate for equal access to services for both refugee and host communities and put in place some mechanism to make sure that tensions are well monitored and as well that proper messaging is being disseminated around. But we shouldn't be talking all the time about tensions and stigma, because if not, this is often being reused and reshaped in media. And that's what we've been seeing in Lebanese media, but not only. If you're looking at the example of Moria, the Lesbos camp and other places, it's exactly the same thing happening. So yes, we want to shed the light on particular vulnerable group. This is very important, but we also want to make sure that it is taken as a comprehensive issue, problem, and not only stigmatizing them. So us, I would say as humanitarian, we have to do our job at the field level and to make sure that it's coordinated for the refugee population. But when it comes to messaging, we have to be very careful. It is very different to advocate for the European population about what is happening in the global south. And when you're doing advocacy in your own country, where you have to be careful, about the backlash, because we don't want what is a very, very acute health crisis to turn into internal clashes and potential wars, which would even worsen what is happening right now. So yes, careful about stigma, acknowledging it, but making sure that there's no backlash, which would worsen the situation.
Carl, in a public health sense, is this something that people know how to do? Like if you're in the Rohingya camps in Bangladesh, for example, it seems a classic case, as Jeremy described, of somewhere you couldn't make more dangerous. So do you say, buckle up, it's going to get bad, or do you not? How do you communicate?
So what is very interesting with this pandemic is that a lot of the success of our capacity to contain the pandemic is relying a lot on the individual behavior and group behavior. You can see that in Europe, but you can say that in other countries. It does mean that we need to make sure they have access to the right information. So just before a call, so I'm the director of this research center on humanitarian action in Geneva, but I'm also the co-director of InZone, providing higher education in refugee camps. So I had a quick call with our local team who are refugees in Kakuma. And as Suze and Virginie said, there's a lot of fear because they haven't not received the right information about what they're supposed to do and not to do. And that's very worrying, I think, in a context like Cox's Bazar, for example, that actually the population has not received the right information about, yes, basically about hand washing, but not much about mass gathering, not much about should we stop school? Is it safe for me to go to the health center and so on. And that's for the population, but it's also for the healthcare workers. I think our key priority for us is to protect healthcare workers right now. They need to get access to this equipment. It's very, very important. They are the ones who are going to respond to the case management. It's very important as humanitarians, we start with that and with the right communication, but evidence-based communication. Cold, clear, transparent information about what to do and what the situation in the camp.
Jeremy, just to kind of broaden the focus a bit, widen out a bit, do we have the international machinery for this pandemic?
I don't think we do. I think one of the lessons from Ebola was, even on that scale, it was a real struggle to deliver the sort of international operational coordination that was required. And so, what we found very rapidly was that WHO was not set up to do kind of that scale of operational coordination for reasons that are best put to the Secretary General at the time. They decided not to use the humanitarian cluster coordination architecture and instead set up this UNMIR special health keeping mission. That also didn't work very well, quite famously. And so, they're trying a different way to do it this time, in which WHO and OCHA kind of work more closely with and through the humanitarian coordination architecture. We will see how that works. I have higher hopes for that than I think I had for UNMIR. So let's see. But fundamentally, this is a huge coordination challenge. It is a much bigger scale than what we are used to dealing with, and it's very, very it's going to be hugely difficult. And I think it's going to mean working a lot more closely with host governments than humanitarians are normally used to doing, because this is not just about providing services in a refugee site or a conflict affected area. This is really about the fundamentals of health systems and as Carl rightly said, about health seeking and health protecting behavior across entire countries. And so that is not something that we are in the humanitarian sector always terribly well set up for. So I think that's going to be a big challenge. Again, not an insurmountable one, but a significant one. And there's a huge logistical challenge here. Get affected countries and the most resource deprived countries get the protective equipment that they need, get eventually, hopefully, the vaccines and the therapeutics that they need. And that's going to be a big challenge too. I don't think we're really quite ready yet for the fights that are coming over limited supplies of PPE, limited supplies of vaccines, and limited supplies of therapeutics. We're already starting to see that on PPE. When a vaccine is created, there aren't going to be 7 billion doses ready immediately. And so we should really, and this is more a political issue than a humanitarian one, but obviously it has implications for the rest of us. When the first 100 million doses of vaccines come out, it's going to be a big fight over who gets those. And it's going to be very important that not just go to those who can afford them.
Well, that's a depressing prospect. Thank you. Suze, if you don't mind, you're part of the sort of classical NGO system where you speak to the donors, you say what you think needs to be done, or in fact, they come to you and they invite you to bid. Is this mechanism going to be sufficient, and how complicated do you think the donor relations and project management will be?
I think, based on what I've seen over the past week, it will be quite complicated. I think in the first place, as was raised earlier, we're seeing donors a little bit preoccupied with what's happening in their own context. Same with NGO headquarters and the UN and others. which means there's been the rest of, in headquarters, I imagine, and among donors, there is a lot of time to dedicate now just to COVID-19, because this is the topic of the hour. But those of us working in the field are doing all our normal jobs. We're trying to maintain a sense of calm. We're trying to ensure messaging is appropriate and contingency plans in place. And we're trying to respond to a lot of extra demands from donors. I think the best thing donors could do now is ensure they're giving time and space to us to figure out what is needed in different contexts. That will take different amounts of time in different countries. It will be potentially easier for those of us who have well-established unHAS transport systems or working road networks. It will be harder perhaps in some of the countries with less established humanitarian systems. So I think donors need to pay attention to that. And finally, I think this will be a catalyst for revisiting some of the donor compliance measures that we're seeing imposed on NGOs in the field, which have been tightening and tightening in recent years, where there is very little risk sharing now between donors and NGOs. We're seeing ourselves carry the burden of all risks relating to security, financial management, the risk of fraud, and that's both time consuming and expensive. We're also subject across the world in many different contexts to a lot of vague language about or strict measures that are preventing us from reaching areas under the control of non-state armed groups. If donors do not take steps now to ensure that we as humanitarians can have confidence that we can safely access areas under the control of non-state armed groups, we will see a much bigger impact in those areas. And we're seeing our humanitarian principles absolutely compromised. So I would like to see donors look as a first priority at their own policies and what impact those will have.
Carl, I just want to pick up that point from Suze. Is there a kind of body of evidence that says that ungoverned spaces can be a sort of reservoir of infection in the same way that they can be a reservoir of extremism? Is that a discourse we should have or we should avoid?
No, I think you should avoid that.
Okay. Why?
The evidence we have is that, and again, it's not for every country where you have non-state armed groups, but it's true that the provision of health services varies in terms of quality and in terms of coverage. So this is an issue we are dealing with in a few countries. Let's take, for example, Myanmar as a good case study. You've got so many armed groups, and the situation differs country by country and province by province. What we have is the difficulty for humanitarian organizations to negotiate access to these zones and to actually provide clinical support to these health services. This is the evidence we have. So in case of the COVID-19, for example, it will be much harder, much more challenging for all the NGOs, who are probably the only ones who can get access to these zones, to actually be able to provide the right management of cases and the triage and the testing. That is going to be very, very challenging.
Okay, so now I'd like to move, Jeremy, if you could take us a little bit further into the future before we run out of time. In the example of Ebola and other health crises, underlying things tended to get worse while all the attention was diverted onto that. And we're seeing some pretty scary possibilities in terms of economic recession and job losses, and export-dependent markets like, I don't know, the Kenya flour industry look like pretty much dead on arrival. Draw us a picture of what might be doable and what might just have to kind of be prioritized.
Well, I think right now we're in a phase of simply trying to get on top of the explosive spread potential that this virus has. So you've seen China achieve that at very, very high cost to their economy. South Korea has been able to achieve that so far at lower cost to their economy. The US has yet to achieve that, and we are starting to feel a very high cost to our economy here, and similarly in much of Europe. I think that's going to be a pattern in a lot of countries, that the initial phase is one of explosive spread that requires really drastic measures to shut down economic activity and social human mobility. In effect, I mean, the human mobility in China was largely shut down for months, and that's what's beginning to happen now in the U.S. as well. And that will, what we see from China is if that is done with discipline and rigor, that does get spread back under control. So China took its reproduction rate for the virus from something like 3 to 3.5 to down to about 0.3, which means that instead of 3.5 people getting it for every one who has it, only one person got it for every 3 people who had it over the course of that. So it's a huge drop. But is that sustainable? You can't keep your economy turned off for the 18 to 24 months that it's going to take, if we are lucky, to have a vaccine available at global scale. And so I think that the challenge is, what does the phase 2 look like? And this is where I think the conversation is beginning to turn to. There was a report that was put out by Imperial College London earlier this week that was quite grim in what it proposed for that. It proposed that maybe we'll just be in a position of toggling the economy off and on, off and on, off and on every few months as cases rise and fall, depending on depending on what we see through the surveillance. I don't really think that's feasible or advisable. I think we do need a game plan for phase 2 that is going to look like much more intensive testing, intensive surveillance, some degree of social distancing continuing, but that allows an economy to turn back on in a safer way. The challenge is all of that, to do that right, it's pretty tech intensive, it's pretty resource intensive. China and South Korea, the 2 countries that have really done this effectively, did so through incredibly sophisticated information technology tools to amplify their contact tracing. I'm not even sure we can do that in the US, much less in most of the developed world. So I think there's a real challenge here, and in the underdeveloped world, in underdeveloped and resource poor countries, it could be quite challenging for them to even get on top of the initial wave, much less to kind of sustain suppression of the virus for the 18 to 24 months until a vaccine hopefully is widely available. So I think the economic damage here is going to be substantial, and most of the economists that I've heard from are already projecting a recession in the US greater than the 2008 Great Recession, and I think that's probably what we're in for globally as well. So it's a pretty grim outlook at this point.
Thank you, Suze. Where do you see things in maybe 6 to 12 months? What bothers you? What do you expect?
I like Jeremy. Right now, I find it very hard to project beyond the next month. Where I feel like right now we're all kind of just sitting on tenterhooks, waiting to see where this will go. And over that period, I think the things that matter most are attention to the economic damage this will do. Even before coronavirus arrived in Somalia, markets were absolutely empty of basic medical supplies, of soap, of hand sanitizer, of buckets. And yet I have a pretty strong suspicion that humanitarian actors will go for the a predominantly cash-based response, because that's our go-to in situations like this. If markets aren't functioning and aren't able to meet those needs, how do we adapt our cash modalities? That's something I think we need to think about. And the other thing, over the next 6 months, we need to prioritize working with governments as humanitarians, as the UN and NGOs, to ensure there are humanitarian exemptions on any travel restrictions, so that we know that travel will be restricted. We know that we'll be relying predominantly on national teams, but how can we ensure that within countries and across borders, to the extent necessary, we are able to travel?
Virginie, I'd like to get your vision of the future, but just take one extra thing, if you would. Is this like the moment for localization, for the globe-trotting foreign aid worker to finally hang up their boots? And secondly, we hear in some places that aid workers are now being stigmatized as carriers of the disease, and there's a sort of aid worker phobia developing. If you could talk to that, that'd be great. Thank you.
So yes, definitely. For me, this crisis shows, and there was no need to demonstrate it, but it shows that localized response are I mean, the only solution in certain settings, but I don't think that this means that, no international actors. We see it in Lebanon. We need the international expertise for certain things, either because of lack of resources or because there are some particular expertise when it comes to camp settings and so on. So I don't think that we have to say, okay, it's localized, and because basically we're afraid that people coming from outside would bring in some risks, we stop it and it's only localized. I don't think this is the approach, or at least this is not the approach in Lebanon. Yes, foreign aid workers were being perceived as potential sources and so on, but to be fair, I think in Lebanon it was quite nuanced. Been reading other reports about other countries where it is true that it was a bit more acute. Now, for the 6 coming months, I want again to be optimistic, because I'm thinking that this is an opportunity for Lebanon to highlight that even prior to this crisis, even prior to the Syria crisis, there was no universal access to public health. The budget of the Ministry of Public Health almost all goes to private hospitals, almost nothing for primary healthcare in country. And now the only way to respond to the crisis is to mobilize the system, because it is not true that private hospitals only can respond. And well, obviously they have no interest in responding if there's not the government, if there's not a humanitarian community pushing on them. So for me, this is an opportunity right now to push for a strengthening, a strong strengthening of our public health system, not because it's a long-term vision, because this is the only way we're going to be able to respond in country, in Lebanon. Also because this system, if we're not developing it, we're going to develop a parallel system over the next 6 months. And that's a bit my concern, is to say basically we will have additional needs, notably for the refugee communities. The public health system cannot cope, so let us develop a parallel system. This has not really been the case in Lebanon till now, even though there were some bad examples, but this has not really been the case. And we should really be careful. And this is what I'm going to advocate and act for over the next 6 months. It's as much as possible, we develop the public system to ensure universal access to health and treatment for these particular things. And hopefully as well, this will be an opportunity to train additional aid workers in country in order to be able to respond to those challenges. And will potentially have also aid workers from our country going to other countries, because I think we have a good bunch of expertise in Lebanon in terms of responding to emergencies, even though not similar health emergencies.
Thank you. Carl, your long-range view, I guess there's a debate in international public health about doing single disease sort of silos versus doing public health systems. And I saw the Global Fund had said that some of their money could go to this new disease, even though they have 3 diseases in their name. How do you see that developing?
Absolutely, that's the way forward. And this pandemic is a very good example of how multi-sectoral we have to be. And it's not a buzzword. In a sense, we need the private sector to be involved. We need transport. We need airlines to transport staff and products. We need international collaboration. We need today we can work from home because internet companies have upgraded their services and so on. So we really see how we need to work not only within the health sector, but with any sector outside the medicine and health, making sure that we can work together. That's essential. If you talk about if I may, Ben, talk about the future. I mean, I've seen around me very much in my village a lot of solidarity, people helping each other, helping elderly people, doing the shopping for them. It's beautiful. I think the sense of solidarity is great. I'm worried about these travel bans for humanitarian purposes. I've heard from MSF they have tried to deploy a team to Iran and they could not do it. And that's very worrying. At the time when we need international collaboration, where Italy needs more ventilators, need more staff to help them, we cannot do it. And that's an issue to me. In a way, this solidarity, national solidarity, is to me interesting, but this nationalism is a problem to me. We have closed our borders, and in a time when we need more international collaboration, and that's an issue for me. The second issue I have for the near future is about human rights. I'm very worried about refugee populations, in a sense, people who are from the outside. I'm pretty sure that in many, many cases, and we've seen that in Greece, and we're going to see that in a few other countries, where priority is going to be given to host populations. And that's an issue to me. It's a huge issue. How are we going to resolve that in the long term? I think it's a problem. So to go back to very much your introduction, where you're talking about philosophy and ethics, I think these are key issues to resolve, or we have to deal with that in the future.
Thank you. I'm trying to gather together some of the questions from the public that have come in and kind of group them together. So I obviously won't get around to all of them. There's a theme in some of the questions, Jeremy, which is, what about everything else? What about locusts? Anybody remember locusts? You know, how is this other things going to even get a look in?
Well, I think that's the challenge always with pandemics, is that or a major outbreak, that it distracts and it diverts and it kind of attention from those other challenges. You know, during the Ebola outbreak in West Africa, more people died of other diseases than died of Ebola, and likely more people died even of deprived healthcare due to the impacts on the wider healthcare system than died of Ebola. So, you know, those secondary impacts are enormous, and I think that's where the focus on continuity of operations becomes very, very important. That it will be vital that humanitarian organizations can find ways to continue to sustain their operations, even as they are A, working to battle this virus, and B, trying to do the best to protect their own people. Because yeah, if we focus all our attention on coronavirus, and meanwhile, you know, some other outbreak tears through a camp, or locusts eat up all the crops in a country, that is a pandemic impact. The pandemic impacts don't stop with the virus itself. They include these second order impacts, which can be just as damaging, if not more so. You think about the damage that is done by shutting down an entire national economy for 2 to 3 months. That will cause a lot of human toll as well, beyond just the people who die from the disease itself.
And do you see, Virginie, solidarity in country? Do you think you could mobilize resources if the foreign aid is distracted or insufficient? You have a huge diaspora, but I know the banks are not looking so good, but is there a mobilization, solidarity going on?
So over the past couple of months already, with the acute socio-economic crisis, we've been seeing diaspora playing a very important role. And this is traditionally the case in Lebanon, with a country which has basically more Lebanese nationals living outside the country than inside the country. So definitely the diaspora has been playing an important role in addressing the social and the economic challenges we've been facing over the past months. This is for sure. Now, what we're seeing with the COVID-19 situation is that those donations are still ongoing. But yes, there are the banking restrictions. And as everybody was saying, now everybody is being very individualistic and thinking about the situation in their own country. So it's quite difficult to mobilize in this particular context. Also, it's difficult because it is true that now you have this risk, and it's more than a risk. It's a reality in certain cases, is that you have nationals who are saying, well, from the diaspora, who are saying, okay, I want to give you money, but this will go only for Lebanese. This will go only for this target population. And that's something which is obviously against humanitarian principles. And I think it's also related to, well, this is not really solidarity. This is charity. So this is not what we're working on, right? So I'm going back to my initial thought. Yes, we're going to have an issue with institutional funding, but I think that this is why it is so important that we're working through the lens of system strengthening. And yes, counting on individual donation, but I really think that if we're working on the system strengthening under the umbrella of the existing coordination initiatives, holding the state accountable to raise that fund, helping them, but holding them accountable as well, will help us to counter those potential threats and actual threats to humanitarian principles and real and effective support to access to health.
Thank you. I've got 2 minutes left. I'm going to take a couple of the easier questions I'm seeing in the Zoom thingy here. Carl, what about testing? If you can't test, then how do you know what's going on?
You don't know? The answer is very quick. Huh? So.
Okay, next.
No, testing is essential. That's going to be the only way governments, ministries, and NGOs will know exactly what is going on and how to triage. It is an essential path. So yes, and
But it's
does
not even happening in Geneva.
It is happening a lot in Geneva.
Is it? Okay.
Yes, yes, okay. a lot at a very high rate.
Okay. Another question for you, Suze, quick one. Can you change, some people are saying, can I just redirect my projects from, I don't know, agriculture or food security or livelihoods? Should I switch my aid work to this and stop doing the other thing?
Yes and no. You could potentially do that if you have the appropriate expertise to offer to a new project. But I would caution against NGOs taking an excessively opportunistic approach to this and diving into something because the money is available. And also, as was said before, and Carl mentioned, prioritization, which essential programs need to continue. We could reallocate funding within them, but we shouldn't step away from them.
Okay, I'm going to
on that point, Ben.
Yeah, go ahead.
Quickly. So one of the things that was most effective on Ebola was where there were programs that had value to add, even if they were oriented towards something else. Layering these additional interventions into existing programs enabled you to get up to speed much more quickly. So with the burial teams in Liberia, for example, those were built on top of an existing community wash program that already had community confidence and participation, and it was close technically to what was needed, the sanitation, obviously different kind of sanitation. But so finding those opportunities for programs that give you a platform and a kind of expertise and buy-in, and building on top of those, not, as Sue says, not in a sort of opportunistic way, but in a way that is strategic, I think it could be a huge opportunity.
All right, thank you very much. We're on Swiss time here, so our time is over. And again, many thanks to our panelists who I think turned out to be an excellent range of opinions and experience. We hope we could do another one soon. We haven't even touched the sort of far horizon questions that I think some of us are starting to consider. But I will be looking forward to reading your feedback online. Thank you to the audience for joining in, and goodbye for now. Thank you.